Good morning. Because of the virus infection, so we have very limited number of attendants, and many faculties canceled this session. But Professor Nakajima and I will deliver our scheduled presentation. So let's invite the first speaker, Jun Nakajima from Tokyo. He will talk about the virtual assisted lung mapping for lung cancer surgery. Yeah, please.
Good morning, Professor John and everybody. So I'd like to talk on a virtual assisted lung mapping, VAL-MAP, for lung cancer surgery. This is a new technique to detect small nodules in the lung through thoracoscopic surgery or robotic surgery. So why do small pulmonary nodules matter? Of course, recently, more small nodules have been detected both in European, American countries and Asian countries. Thoracoscopic surgery or robotic surgery has been familiar, so direct finger palpation is difficult through VATS or RATS. Moreover, ground glass opacity nodules, GGN, GGO, are softened. They cannot be palpated even through open thoracotomy. So techniques of localization for pulmonary small nodules through thoracoscopy have been developed. Visual search or direct palpation is a conventional way through open thoracotomy. Then the tactile sensor or ultrasonography is performed to detect a small nodule intraoperatively. But preoperative marking methods are more familiar. CT-guided hook wire placing, coil placing, barium placing, lipiodol markings have been widely used. So under chest fluorography, 3D virtual bronchoscopy, and electromagnetic applications are used to assist the intraoperative detection of nodules. Hook wire placing, excuse me. So this is a barium marking technique with fluoroscopy. For detecting a small GGO nodule, barium was inserted via bronchoscopy, and under fluoroscopy observation, wedge detection of the nodule is performed. CT-guided hook wire placement is the most familiar technique to detect pulmonary nodule. This is a product from Japan. The tip of the needle is hook wired, and it is connected to nylon suture. So under CT observation, hook wire needle was inserted near the nodule. We can easily find out nylon suture on the surface of the lung, which is a landmark of the nodule. CT-guided hook wire marking is an easier technique to detect small pulmonary nodules for resection. However, serious fatal complications have been reported, as well as minor complications such as pneumothorax or bleeding. This is a case report of massive air embolism of left heart system after hook wire placement. You can see the massive air here in the left ventricle. And this is another case report of left heart system air embolism. You can see massive air in the ascending aorta. It is thought that communication between pulmonary vein and the airway may be made by hook wire insertion. The incidence of minor complications after hook wire placement frequently occur. Pneumothorax or bleeding can occur 30 to 50% of patients after hook wire placement. Incidence of air embolism is predicted to be 1.5 to 1.9% by literature. By these reports, we stopped to perform hook wire placement in our hospital. After that, we employed virtual assisted lung mapping, VAL-MAP technique, to detect intrapulmonary small nodules for resection. VAL-MAP procedures is basically a dye marking through bronchoscopy. To make precise marking, 3D virtual bronchoscopy is used for navigation. And this is a thoracoscopic finding after VAL-MAP marking. So you see the video. So here, so you can see the blue tattooing on the surface of the lung. So VAL-MAP is expected to satisfy position identification of the region, reproducible and reliable results, and secure safety of the patients. The idea of VAL-MAP is multiple marking to specify an area including pulmonary nodule. It makes us easier to decide area to be resected. Here, mapping it means the multiple die making here. And I'd like to show you the procedure of VAL-MAP in a case. In the beginning, so we perform the high-resolution CT, and we plan to select bronchi for die marking. So here you can see a small nodule in a red circle. And so we make up 3D images of the lung. Blue spots are predicted to a location of die spots on the lung after marking. And pulmonary nodule is shown as a red spot here. You can see. And then we stimulate to reach the sites of the die marking by virtual bronchoscopy. So it can be made up by the high-resolution CT. Okay. And with the guidance of virtual bronchoscopy, a real bronchoscopy is performed. Indigo carmine, that is blue dye, is injected as subpleural region for tattooing pulmonary surface. So as you shown you before, so we can make a tattooing of the lung surface. So we performed a prospective multi-institutional VAL-MAP study to confirm safety and reproducibility. We performed 1,774 markings for 681 targets in 500 patients by 18 institutes. And mean diameter of the pulmonary nodules is 10 millimeter, and majority of the nodules are ground glass nodules. Most of the nodules were resected by wedge resection or segmentectomy. So first, almost all VAL-MAP markings were able to be detected. So only the white column is the nodules that can be detected, regardless of hospital or surgeons. So it is a very reproducible study. And we observed less than 1% severe adverse events, and we think that VAL-MAP technique is safely performed. And successful rate, that is the rate of detection of the pulmonary nodule was 99%. It's very precise. And we have a consensus that sufficient surgical margin is important to prevent local recurrence of lung cancer. This Kaplan-Meier curve figure shows that the distance from tumor to surgical margin affects postoperative local recurrence. This paper is the very similar one. The distance between tumor and cut margin affects local recurrence. So in our prospective study, criteria of secure surgical margin was set to be more than or equal to 2 centimeter or diameter of the tumor. It was nearly achieved, but distance between surface and deepest surgical margin was left as a risk factor. So more than 10% of cases were failed if the required depth of surgical margin was more than or equal to 30 millimeter. So the nodule located deep in the lung is the problem. So to overcome the problem, we revised original VAL-MAP into VAL-MAP version 2 to secure the deepest surgical margin. That is fiducial placement through bronchoscopy on the deepest place to be resected. We secure the surgical margin at the deepest lung here. And to left upper figure shows a three-dimensional lung map. The locations of die marks and intravbronchial microcoil are planned using 3D images. The intravbronchial microcoil is planned to locate centrally to the tumor to indicate the deep resection margin. Intra-bronchial microcoils plan to locate centrally to the tumor to indicate the deep resection margin. Right upper figure shows that the virtual bronchoscopy indicates the planned location of a microcoil on the arrow line. Dye markings and the coil are observed by CT, left upper figure, and the stapler is applied to determine the tentative resection line based on the dye marks on the lung surface. And fluoroscopy is used to localize the microcoils, which indicate the necessary deep resection margin. So if necessary, the resection line can be adjusted by fluoroscopy examination. So I'll show you a case of a patient with a small nodule located deep in the left lung. We performed VAL-MAP version 2 before surgery for the patient. So we set 4 dye markings and 2 fiducial placement microcoil through bronchoscopy, and under fluoroscopy, wedge resection was successfully done. This is a resected specimen. The microcoils are also resected, and the tip of the needle is the estimated location of the tumor. Recently, we applied electromagnetic navigation bronchoscopy system. This is the super dimension by Medtronic to VAL-MAP. By electromagnetic navigation, tip of the bronchoscopy is navigated and superimposed to real-time 3D CT image of the patient. With electromagnetic navigation bronchoscopy, we can do mapping and surgery at one time under general anesthesia. It is beneficial for the patients. I will show you a case of the patient who suffered from the second lung cancer after left lower lobectomy. By high-resolution CT, 3D CT, and virtual bronchoscopy was made before the procedure. We plan to reach the target region through bronchoscopy. Here, so the green ball is the target. And through a bronchoscopy, seeing the virtual 3D CT images, so we approach the tumor like that. I show you, this is the method for the biopsy of the tumor, and we applied this technique to mapping. This is the combination of VAL-MAP and electromagnetic navigation. In this time, the target is not a tumor, but a lung surface, pleura, to be mapped. And now, we are approaching to the pleura to be make a tattooing. Here, green ball is the target, like that. And we made a multiple marking, and we can do a secure wedge resection for the patients. This is the tattooing of the lung surface here. Okay. And in summary, virtual assisted lung mapping, VAL-MAP, is performed with the aid of 3D CT, virtual bronchoscopy, and dye markings through bronchoscopy. It specifies the area to be resected, not only the place of the pulmonary nodule. And it is a safe, reproducible, and reliable method. And it is more powerful and fiducial coils for deeper resection. And VAL-MAP is more conveniently performed with an electromagnetic navigation bronchoscopy. Thank you very much.
Thank you, Professor Nakajima. Thank you for your excellent presentation. Do you have any questions or comments? So you perform this time marking after anesthesia before surgery?
So for the VAL-MAP 1 and VAL-MAP revised VAL-MAP, we perform for the patients. So usually just 1 day before the surgery. So under light anesthesia, we performed.
IV anesthesia or intubation?
No intubation, but so we made IV
anesthesia. Yeah, okay, very good. So any other questions? Yeah.
Thank you, sir, for your nice presentation. Thank you very much. I just want to know, is this valve mapping is like cost effectiveness regarding other available hookware or other things? So what do you think, or what will be in the future also?
Yes. So yeah, because so we should do VAL-MAPing for the patients just before day. So we should do a bronchoscopy, 3D image CT scan. So it costs. Moreover, so when we use electromagnetic navigation system, super dimension, it costs very high. And so in Japan, so the government does not pay for the ENB. We do as a clinical study. As an ENB. It is a problem. But before the VAL-MAP, so we performed the hook wire placement through CT. It is very convenient. But there are many. There are not many, but several severe complications of air embolism of left heart system. So we fortunately did not meet such patients, but we changed. It is for the safety of patients, not for the cost. Is it okay?
Yeah, when you visited his center, did you observe this procedure? At that time, no? So he visited your center before?
Yes.
Yeah. Yeah.
So it's very good presentation. So I learned a lot from you. So I have one question is that between, you said you do the VAL-MAP before you go in the operations 1 day. So is it different if you just go in, like ENB, you die localizations after you switch the patients and do surgeries? Is it make a difference?
So you mean that it will take around 1 day from tattooing and surgery. So is it any change? You mean?
I mean, like, is it different that you perform immediate before?
How about
I see. I tried some study. So I think that the duration of about 2 or 3 days is okay. So the tattooing is not diminished or disappeared. So it is convenient for us because because the day of the surgery we are very busy. So we perform the tattooing just before the day of the surgery.
So technically, it can be done just before surgery. But the environment, the situation, operation room or human resource, you are doing 1 day before.
Yeah. So usually, in actual, now we routinely do a CT scan just after the VAL-MAP to secure the placement of tattooing. Yeah. So if we can skip this procedure, so I think that we can do a VAL-MAP and then immediately surgery.
So how can you recognize your tattooing in CT scanning? It appears a kind of some haziness.
Yes. So we cannot recognize the color of the.
No. In
of course.
In CT scan.
Yeah. So by CT scan, we can recognize the tattooing by a small infiltration, just before beneath the pleura.
Okay.
Thank you.
So any other questions? Okay, thank you very much.
Thank you very much. Okay. Good morning. Okay, so the second speaker is Professor Jung from Seoul National University about the clinical pathway for VATS lung cancer surgery. So please start the lecture.
Good morning. I'd like to talk about the clinical pathway and how our system can support the VATS lung cancer surgery. Next slide. As you know, clinical pathway is interdisciplinary plans for care, which outline the optimal timing and the sequencing of clinical activities or interventions for patients presenting with a specific diagnosis, procedure, or symptom. So what is the difference between clinical pathway and the clinical protocols? Protocol is treatment recommendation and the guideline compliance, and may not include the continuous monitoring and the data evaluation. Aim of the CP is to improve quality of patient care and to improve multidisciplinary communications and to help identify and clarify the clinical process and to decrease practice variation among surgeons. So what we can expect from the CP application? In terms of the quality of care, we can provide standardized care to minimize potential complication and provide adequate information to patients so we can maximize patient satisfaction. In terms of work efficacy, so it can provide stability of workflow, practice consistency, and the interdepartmental cooperation will be better so that we can minimize work burden of the resident. So better communication among medical staffs and the doctor to patient. So doctor satisfaction will be increased. In terms of administration of hospital, quality control strategy can be used. So it is cost effective for length of stay, inpatient bed turnover, or minimize insurance cut-off, so hospital can also satisfied. So we have many clinical pathways are running in my hospital, more than 200 CPs. In the department of thoracic and cardiovascular surgery, we have about the 10 CPs are working not only for thoracic but also in cardiac surgery. The component of the CP is as timelines from the admission and preoperative, intraoperative, postoperative, and discharge, and the categories of care, activities, and intervention from monitoring, medication, teaching, laboratory, and the treatment plans will be applied to clinical pathway. Before we making the clinical pathway, we summarize a care list by timeline. So what is goal of a clinical pathway? What is indicator for improvement? What we should do for doctors, nurses, activities are summarized by timelines. So this is the doctor's page of our electronic medical record system. As you can see, the yellow circle in EMR, electronic medical record, if CP is activating, you can see that the VATS major pulmonary resection CP is working. So when the resident check his inpatient, so they can very easily recognize which patient is on CP. And we have many CPs in the thoracic surgery, about 6 or 7 CPs are working. So we checked the status of our CP application. So rate of CP in VATS major pulmonary section, year by year, the CP rate is increasing and the CP completion rate is also increasing. So we checked about more than 1,200 cases of VATS lobectomy case. We made 3 groups. First phase, CP introduction, second phase, the CP transition, and the third phase, the settlement. As you can see that the CT completion rate is increasing year by year, and we are more than 70 or almost 80% of the CP applied cases completed by CP. So we checked many parameters and made analysis of the multivariate. So the pulmonary complication, hospital stay, and the planned discharge and hospital cost, and the pain and the discharge. So all of the many important key index showed improvement by CP. So we can say the application of CP for lung cancer patient is feasible, and the multivariate analysis showed both settlement group, so which means the latest group, and the CP completion group had a better outcome in terms of the pain score, pulmonary complication, and hospital stay, planned discharge, hospital cost, and the reduction rate. So we say by our intermediate analysis, the implementation of CP has a positive effect on process quality, outcome quality, and the economic quality. So we have some concern about the CP application. This is just like the cookbook medicine, and we can block the young doctors' thinking, young doctors' innovative thinking, we can block, and it's a cost transfer. To fit the CP, we tend to make our patient discharge more earlier, but which makes readmission or complication developed after discharge. So just the cost of transfer from inpatient to outpatient. But the result shows the potential limitation of autonomy. This is not a set order. So it is we can make the better understanding clinical situation. And this one better understand for standardized practice, and the length of stay will be very flexible in our system. So we made a survey to our resident. What do you think the advantage of CP? So they say that medication order, very simple, because some antibiotics order is very different, surgeon by surgeon, but it is standardized. So the resident is very easy to make the antibiotics order. So if the antibiotics order is not correctly, we can automatically block. So our principle for VATS lobectomy or VATS segmentectomy, first rule is first injection of antibiotics within 1 hour within 1 hour before skin incision. And antibiotics should be stopped within 24 hours after VATS lobectomy. So this is very simple. Selection of the antibiotics is a single dose of the cephalosporin in the first generation. And the second advantage latent replied is they had many orders. First day, second day, just one click of the signature, or the electronic signature, that's fine. So it is very simple in one click signature. And a very easy communication among surgeon by surgeon, nurses, patient. So it is very easy communication. These are advantages from latent feedback. Beside the clinical pathway, we provide supporting systems, clinical indicators. For example, antibiotics prophylaxis, pulmonary resection, every 3 months we have feedback. In the first quarter, second quarter, third quarter, fourth quarter, so timing of the antibiotics injection and the selection of antibiotics and the duration. So every 3 months we have a feedback how antibiotics were given by our recommendation. If the antibiotics was given given not within our criteria, they will give this kind of feedback. Why this percent gave another additional antibiotics. And the clinical dataware is also very excellent system for clinical research. So we can put our clinical dataware, we will put in the queries, for example, VATS lobectomy, and the patient used the energy device like a harmonic scalpel during surgery for diagnosis called lung cancer, year from the 2005 to 2009, for example. So these data will come retrieved by Excel within few seconds. So we can very easily use this system in clinical studies. So if you are curious about whether when we use the energy device during surgery, can we minimize pleural drainage after surgery? You can make a query, so we can very quickly have a feedback from our clinical data. And the database is also integrated our EMR system. Our lung cancer database has 13 pages of a database, preoperative and operative record, and the pathology report, postoperative courses. So we have the 13 pages of the 13 sectors of the database for every lung cancer surgeries. This system is embedded in our electronic medical record system. We can very easily sort out the clinical result of the patient. Also, the tissue banking, cancer tissue, normal lung tissue, blood and the bone marrow, how many stocks, how many samples are in the tissue bank. It is also embedded in our EMR system. It is very nice tool for when we do the basic research. So how many cases of the adenocarcinoma, EGFR positive, how many lung cancer tissues are in the block, so we can use them our basic research. This is a very nice tool for obtained. This is just a kind of sporting big data studies. So also we are providing periodic data analysis. This is our lung cancer data. Last year we performed 705 of the primary lung cancer surgeries, and this is the proportion of the open surgery and the VATS. So the last year data, 1 year data will come, but next month, January, every January, we can retrieve the last year's data very easily by our system. So this is the changing trend of the mixed GGO. How many solid and how many GGOs we can check year by year very easily provide. And this is a waiting time. After completion of the evaluation, patient determined to do surgery, how long patient need to wait. Usually waiting time is increasing, but by this waiting time checker, we can apply how we can use operation room properly and how we can make effective inpatient bed turnovers. So the survival rate is automatically calculated, provided by surgeons every quarter, every year. So this is overall survival by pathologic staging. This is cancer-related survival by pathologic stagings. So these data is very important to every surgeons and the latent to always think about how our process and our procedure is maintained. Of course, our complication rate is automatically give feedback to doctors, so we can alert for how many complications will occur after surgery. This data is published by Clinical Outcome Book. This our clinical data is open to our patient and the public. This is a very good tool for communication with the public, communication with the patient, and this is a very good motivation for making our effort to better clinical outcomes. So in summary, clinical pathway is an effective system to provide standardized care, better communication, minimize working burden, and the patient satisfaction. Supporting system using information communication technology is also important for quality control, and easy to understand the clinical flow of breast lung cancer surgery by whole and the details to young surgeons and the surgical team. Regular evaluation and upgrade is necessary to maintain best quality of clinical practice. Thank you very much for your attention.
Thank you, Professor John, for your very excellent lecture. So do you have any questions or comments? So may I have a question? So maybe the clinical pathways. So you have a very organized clinical pathway, but so how about the patient's eligibility? So so do you include the patients with a very high age, very old patients, or the patients with complications?
Yeah, we have eligible criteria. So the potentially very high comorbidity patient will not be included our CP. So we have here. This is number of candidate, number of applicant. So some cases, usually most patient with the high comorbid, high risk patient will not be included in this CP. The patient needed to provide antibiotics several days ago, something like that. So it is not included in CP. Yeah. We have criteria.
So it is very it is very wonderful that so almost all the patients are included in the CP.
Yeah.
Okay. Any questions? Okay, please.
Is this applicable only to cancer patients, or do you include other major resections like thymus and?
Yeah. We have the CP in VATS major pulmonary resection, which included the benign disease or inflammatory disease as well. But we data analysis separately, the primary lung cancer and the others. Yeah.
Any other questions? Okay. And so your clinical pathway is directly connected to the database system. So it is very wonderful for us. Yeah, because the post-operative survival rate is directly calculated from this data.
Usually we are. In my department, we have the data coordinator in thoracic part and cardiac part. We have 2 data coordinator in thoracic surgery part. They are very excellent for doing this kind of jobs. So not every moment we are doing this one, but every end of year we do this kind of analysis, and the report will be given within January. And then whenever we need to data, they give us a very excellent result like this. So by our database, this kind of the overall survival and the cancer-related survival, these data can be retrieved by our EMR embedded database. Yeah.
So I think that there are very high amount of efforts to make a follow-up. So who make a follow-up for the patients?
Yeah, we are all electronic system controlled. So if the patient is not coming 3 months after planned follow, our coordinator make a phone call why you are not coming outpatient clinic. So every month we sort out the list of the patient losing follow. So some case they are already passed away, or they died by the cardiac arrest, or they are doing very good, but not just coming, or visiting other hospitals. We are checking everything. So when patient discharge, we give this kind of explanation. During follow-up, if you are not coming, our department will make a phone call. Please respond for our critical quality. So about 99% can be followed, but some of them cannot follow. In case every year we are checking to government whether patient is alive or die. At that situation, we don't know cause of death, but most patient is very compliance to the phone call. We have listing not only one phone number, we list 2 or 3 phone numbers by relative or son or daughter or the family members.
Yeah, thank you very much. Any other questions? Okay.
The forecast should be shared by the surgeons. the hospital administrative staffs and the government as well. So how are you allot the task assigned? For us, resources is very limited, and we have to order all the jobs to be done by my junior surgeons and my trainees doctors. And in case of your implementation, how do you assign, or how the tasks are assigned?
Yeah, we do not give data to the government. We just provide the government a very limited kind of data.
Yeah.
So the government has data by the insurance payback. The government has the insurance system control, so they have data. So we just reported, for example, number of surgical cases annually, and the sex or age or very simple data we report to the government. And the detailed data we only control in our hospital. So of course, hospital administration can check the complication and the mortality. In every mortality will be reviewed by the hospital. Is it the mortality is reasonable or explainable or not reasonable? So in case our ethical committee is activated, why this mortality was happened? So this is our system. So some data managers are in my hospital, in my department. Some department in the hospital department are doing some part of job, and my department data manager do this kind of jobs. It is very much integrated. Also, we have integration to the tissue bank as well. Yeah.
Thank you, I understand.
Any others? So thank you, Professor
Thank you.
John, for your excellent lecture.
Because of the many topics of cancer, so next session is about the cancer. We can go break or go break.
But if you want to write